Defined for you, can you explain it in short, simple sentences to somebody else? Where are we going? All right, enough preaching. You gave me the pulpit, I had it. All right, so thanks to the venue, the Red Shores, we're going to have a wonderful, amazing lunch, and we'll be around, we're back at the Haviland House at 8 o'clock for the social this evening. All right, so let's get rolling, and we're going to start with David Klein. And David's living in Windsor, working in Windsor for EHS. He's the married father of 3, 2, 6, and 8. So I figure he's going to have like a micro sleep. Or he's so excited to be here and not with the kids for a few minutes that we won't even be able to calm him down. But either way, that's a busy house. I was there at one time, but now our kids are much older, 12, 16, and almost 20, so they take care of us. I'm now allowed to have a beer in the community because I just get picked up by my kids at this point, so it's really quite helpful. Anyway, so David is, let's say, an ECG guru who has been knocking the socks off people around the region with a really cool and unique educational background that includes Sunnybrook Center for Pre-Hospital Medicine in Toronto and the University of Texas. Entrepreneurial spirit, has developed a website and a program called Current, and he's the lead instructor with that. Has recently added a podcast, I believe. And here representing Current and himself and doing just a wonderful job, and really going to help all of us with our ECG understanding today. I have no doubt. Mr. David, come on.
All right, hey everybody, how's it going? Good? Awesome. I'm not going to use a microphone because anyone who's seen me do something like this before knows I tend to wander around. I'm really happy to be here. I really appreciate PAPEI for having me back. I've been here a few times. And I'm going to give you hopefully sort of a fun presentation on ECG interpretation. That's my passion. And you know, I'm going to move around. I'll probably end up on somebody's lap at some point, so just go with it. We'll have fun with it. I recently started something called Current ECG, and it's a video podcast series that you can check out. And really by the end of this presentation, I kind of hope to have you all literally depolarizing right out of your seats. So when I do these talks, I always try and say right away that we don't read ECGs. We interpret them, right? We interpret them within the clinical context of our patients. And that's a really, really important concept for us to get our heads wrapped around. Right? It's not good enough just to be able to read a piece of paper. You have to be able to interpret it in the right hands. That's a valuable tool. Because pattern recognition doesn't work anymore. Anyone can be taught to read a pattern, right? You get that little piece of paper, you look at it, and you say, oh, I see this, I've seen that before. But what does pattern recognition really do for us? Not a whole lot. You have to be able to apply it to something else. And when you do that, it's like learning a new language. Okay, so anyone here a Star Trek fan? Yeah, a couple. So this is the Klingon word for success. And so I really believe that when you guys start getting through on cutting edge ECG interpretation, it is going to feel like you're learning a new language in the beginning. Right? But when you do that and you stick with it, you're going to have a lot of success. Because you need to have that background and understanding at 3 o'clock in the morning. And I'm always ranting about 3 o'clock in the morning because it's true. You guys know. At 3 o'clock in the morning, when you have a call or a patient that you see, it's usually one of two things. Unfortunately, either they're intoxicated or they're just really, really sick. And at 3 o'clock in the morning is when you're tired. I know when I'm at 3 o'clock in the morning when I do calls, I'm hangry, right? I'm tired and I'm using my, my skill of ECG interpretation and that studying of it to help me have success at 3 o'clock in the morning. Who's done this call before? I've done this call 1,000 times. Yeah, you walk into the house, right? You walk in, it's usually like a bungalow, it's in an okay neighborhood. You walk in and you see like the 1970s shag carpet on the floor. It's usually like a burnt orange color. You know, you see some couches and chairs that are covered in plastic. You're walking towards your patient. They're usually seated in sort of a recliner. There's oxygen tubing. There's a stack of medication sitting next to them. There might be a lit cigarette, who knows. There's usually a lamp that's right behind them that's kind of one of those old lamps that has that long arm that angles out with the lampshade. You guys know exactly what I'm talking about? Yeah, great. Exactly. And you're looking at your patient and you're trying to figure out, you know, what's wrong with them? What am I going to do as part of my assessment? And of course you're going to listen, you're going to be, audibly you might be hearing them wheeze. You're going to look on the table and you're going to see things like nitro and Venolin. And you're like, okay, is this COPD I'm dealing with? Or is this cardiac asthma that's causing the wheezing? And so you're relying on what you know to make a good assessment. But at 3 o'clock in the morning, when you're really tired, that's when you're kind of, you're willing to take more risk with your patient. And we don't want to take risks. We want to use our knowledge and be able to have that in our heads and rely on it to save us to make the right decisions. Okay, cool. So, do you know the technology of ECGs, the ability to perform it as a technology, is over 100 years old? It's been over 100 years now. And basically, there was a doctor, his name was Dr. Eindhoven. He hooked himself up some electrical wires to a conductor. He filled a big bucket of water, threw some salt in it, stuck his leg in it, and flipped the switch. And that was the first semblance of an ECG that we've evolved into today. And he went on to create something called Eindhoven's triangle. Okay, and it's still widely successful today. Our limb leads, 1, 2, 3, right? AVR, AVL, AVF. So we still use the principles that Dr. Eindhoven taught us years ago. Now, understanding that ECG interpretation is an incredibly influential tool. Super influential. It can influence how you look at your patients who are complaining of things like chest pain or shortness of breath or you know, jaw pain or teeth pain. So it can influence how we look at them, and it also can influence how we perform further investigations with our patients. Being able to accurately interpret the ECG really influences how we continue treatment and then how we pass on that information to, say, a receiving facility. So just know it's super powerful and very, very influential. And there's also some cool research that's being developed right now, which is talking about the psychology of chest pain. Okay, the psychology of chest pain. And so just have a listen to this for a second. So did you know that there's some patients out there that are answering questions that we're asking them, that they're answering them in a way that they think we want to have the answer. So let me give you this example. How many times have you done this? You go to a patient with chest pain. Okay, it's Mr. Jones, right? You say, hi, Mr. Jones. Take a big deep breath for me, Mr. Jones. Does the pain change at all? Mr. Jones, move around like this. Does that pain get any better or any worse? Mr. Jones, I'm going to put a little pressure on the center of your chest. Does that pain change for you at all? Mr. Jones like, yeah. But there's some psychology that's saying subconsciously, Mr. Jones may be just answering yes, because Mr. Jones is suffering from something that's scaring him in his body. He doesn't know how to convey that to us. And so what he's doing is he's trying to answer the question the way he thinks we need to hear it in order to convey the level of fear he has. So just know that sometimes patients are subconsciously answering questions in a way that they think we need to hear it. Because they're not trained medically, they think maybe the answer is yes. Cool, so another concept here, EOCOR. So EOCOR stands for the International Liaison Committee on Resuscitation, and there's usually 3 little letters after that stand for emergency, ECC, which means Emergency Cardiac Care. Basically that's a group of physicians, nurses, doctors of all kind, and they get together, they do research, they go away, they find that they clinically research their findings, they get back together after 5 years, they present them to the group, and then we update all our recommendations in emergency medicine. So every 5 years, EOCOR releases a new edition. And for me, EOCOR is like Christmas. Like 5 years when it comes out, I'm just pumped. I get this book, I study it to no end, and then I use that to guide my treatment based on the latest recommendations. And so what EOCOR was saying, in the latest edition, they started talking about things like the pre-hospital ECG. Right on, thankfully. They started to say, well, maybe the pre-hospital ECG is the most important one. Because we are there at the moment when the most acute process may be happening. And so we're more likely to capture a dynamic change. And that's the other cool thing for you guys to try and think about and remember from today. That the process of acute coronary syndrome, it's a really dynamic one. Okay, so it's possible that you can have a little bit of plaque rupture, that little piece of plaque that goes distally down the artery, it occludes it. okay, the monitor starts to show big signs of ST segment elevation. But your body has built-in T and K, right? We have clotting factors and built-in T and K to break down clots. And your body starts to break down that little clot, and all of a sudden that artery is reperfused again. And now your monitor's showing normal sinus rhythm. How many times have you done a call like that? Go star, 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 STEMI or acute MI suspected. Next one you do says no sinus rhythm. Then the next one changes again. And you're thinking, what the hell is happening? It's because this process is really dynamic. And about 15% of all acute coronary syndrome cases, this process takes place of cyclical occlusion and opening and then occluding pattern. So this is happening all the time. So just know that that's true. And the other thing about EOCOR, which is really cool, they started to say, okay, we need to look at the pre-hospital ECG because they're the ones capturing this dynamic process at the very moments it could be happening. And that, you know, if we're going to ask the pre-hospital provider to capture that ECG, then why aren't we training them to interpret it accurately? And so that's the other thing EOCOR was talking about. They were saying paramedics in particular need to be trained to interpret ECGs. And we now recognize that paramedics are just as good as interpreting ECGs as anybody is. Anyone. Right? You can go up against any doctor, nurse, whoever. If you apply yourself and study this stuff, it's not rocket science and you can do it. So this is a picture of the cardiac monitor. Okay, the cardiac monitor does all kinds of cool stuff. Right? You can pace with it, you can cardiovert with it, you can defibrillate with it, you can do multiple sets of vital signs, you can do end-tidal CO2 monitoring, capnography, and out of that little tiny piece of, or little tiny slit here, comes your ECG, and in the right hands, it's an incredibly powerful tool. So the monitor is programmed based on a whole bunch of sensitive mathematical calculations, okay? And it can be very accurate. But the monitor can't tell you everything. It can't. Okay, the monitor can't pick up on certain types of very sensitive changes. And so when I was trying to get my head wrapped around that concept, it always came down to things about these terms sensitivity and specificity. And I'm not a researcher. Okay, I'm not. I don't think like that at all. And I was like, what does this sensitivity and specificity mean? Why is it important to me? And so if you look here, this IMI stands for inferior myocardial infarction. AMI stands for anterior myocardial infarction. So if you look over here, the monitor has a sensitivity of about 72% and a specificity of about 100%. And so you guys are sitting there thinking to yourself, what is he talking about? And so I was the same way, so I had to come up with an interesting way to describe this story. And so here it goes. So when I was really little, okay, my favorite thing to do on Saturday mornings, I was allowed to watch Sesame Street, which I loved, and little Dave was allowed to have a bowl of Fruit Loops. So I would sit in front of the TV with my Fruit Loops and I'd be watching Sesame Street. Now, my favorite part of Sesame Street was something called One of These Things Is Not Like the Other. Do you guys remember that? No? I'm old then. So there's this thing called One of These Things Is Not Like the Other. Basically, three of the images are doing the exact same thing, and one of them is doing something completely different. So if little Dave could tell his mom, so if I could say, show to my mom, which of those things was different, that's an example of sensitivity. I was sensitive to the change. Okay? Now, if I could tell my mom exactly, specifically what was different, that's an example, in this case, of specificity. So if I could know that something was different, that I was sensitive to the change, but if I could tell my mom specifically what was going on that was different, that was an example of specificity. Okay, everyone go with that. So we get back to this whole concept here, with respect to the cardiac monitor. The monitor has a sensitivity of about 72% and a specificity of almost 100%. So that means when the monitor spits out star, 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 acute MI suspected, you should strongly consider this might be an MI. Not to say there's not things out there like STEMI mimics, and I get it, I know, there is, for sure. I'm just saying in your differential, put MI sort of higher up on the list. Because when the monitor sees it, it definitely sees it. The problem is, the monitor only has a sensitivity of 72%. That means 28% of the time, it will miss it altogether. Completely. Okay, and that's why you're sitting here. right? Because we need to be able to interpret the ECG ourselves so that we don't miss that 28%. That's a big percent of the population. That's your mother, that's your father, that's your sister, that's your brother, that's your grandparents, that's your loved ones. And so that's why you need to know that the skill of ECG interpretation as pre-hospital providers or emergency clinicians, nurses, doc, is vital for us to be able to interpret it. Because we can't always rely on what the monitor is telling us. Okay, cool. So that gets me to my first sort of fun topic that blew my mind and changed ECG interpretation for me forever. That's this concept of current. And I mean currents of injury. Yeah. So just bear with me on this. Okay, because once you get your head wrapped around currents of injury, it's a game changer for interpreting ECGs. So what do I mean by currents of injury? Here we go. We're back to the cell. Yeah, everyone's like, no, not the cell. So I'm not going to go deeply into cellular physiology, but for the purposes of this talk, I'm going to drive it home on how this works with currents of injury, it's called. And currents of injury, when they exist, they're what show the changes on an ECG. And so here's the deal. So if we're looking at the cell, okay, we're talking about positively charged ions and negatively charged ions. So negatively charged ions are things like chloride and sulfates and phosphates. And there's positively charged ions, and then some of them are like sodium and potassium and calcium. Cool? So, with respect to the cell, there's more negatively charged ions inside of a cell. There's more negative inside of a cell. And there's more positively charged ions outside of a cell. And that is why the resting membrane potential of a cardiac myocyte is negative 90 millivolts. Because the inside of a cell is relatively more negative than the outside of a cell. And if you guys want to know exactly why it gets to negative 90 millivolts, it's wicked cool. Just catch me on a break, I'll tell you. It'll blow your mind. Okay, so the inside of the cell rests at negative 90 millivolts. Now, here we go. Currents of injury. So, when the electrode is sitting on your chest, okay, what the electrode sees is it's looking out at the cardiac or the muscle, the myocardium. It's seeing the individual cardiac myocytes of your heart. Okay, the electrode is looking at them. What the electrode is seeing is it can only see what's happening on the outside of the cell. Okay, the outside. The inside of a cell, the electrode cannot see into. It doesn't know what's going on the inside of the cell. It knows what's happening on the outside. It can see it. Is everyone cool with that? Okay, so when a normal depolarization happens, if you picture that you're the electrode, you're looking at the depolarization happening in a heart. Okay, so at rest, when you're looking out at those cardiac myocytes, everything looks positive. Because remember, the outside of a cell is always more positive. And you can't see the negative on the inside of a cell. So when you're looking out at the cardiac myocytes, because you see the outside of cells, everything looks positive. Does that make sense? Now, when a depolarization happens, right, sodium channels open and tons of sodium rushes into the cell. And so what happens is all of a sudden the inside of the cell becomes really, really positive, plus 30 millivolts. And the outside of a cell starts to be negative. They've switched. Does that make sense? Cool. So you're the electrode. So at rest, you're looking out at the cardiac myocytes and you just see tons of positives because everything is at rest and you see the outside of the cell, which is more positive. Boom, a depolarization happens. And all of a sudden, because your heart contracts from endocardium to epicardium, from the inside to the outside of the cell, the electrode, you start to see everything changing. All of a sudden, all the positives start to go, from the inside, start to go negative, 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 negative. Like this wave coming toward you as an electrode. Because all of the cells are becoming more negative on the outside because all the positive is rushing in. Does that make sense? Cool. So that's what's happening when a current of injury happens. We'll get to this in 1 second. So that's regular depolarization. Now when you have ischemia, so when you have cells that are hurt, they're injured, they're not getting the sugar water oxygen to survive that they need. They can't depolarize the full way. They can't do it. And so what happens is those cells that are injured, they can't get the sodium, can't rush into the cell during the depolarization. It can't go in. And so what happens is the outside of those ischemic cells still look positive. they still look positive. And the electrode sees that. The electrode is seeing all of a sudden negative, 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 and then all of a sudden you saw this clump of cells that stayed positive. And that is the area that is hurt, and that negative to positive flow in that injured cells causes what's called a current of injury. And there you have it. And what do you see on an ECG? This. There's your injured cells. Here's your electrode. These cells are all healthy, so when the depolarization happens, these all start going negative, 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 negative. Boom. These are positive, and boom, this is what you see. ST segment elevation changes. The morphology of the ST segment rises because the current of injury is seeing that injured area of tissue coming specifically at it. And that's why you get ST segment elevation, because there's a current of injury pointing right at that electrode. It sees it. The other electrodes may not see it, and that's why you may not see changes there. That's why that's happening in specific regions on an ECG. Now, what if you put an electrode on the other side? Over here, it sees the wave of depolarization and the current of injury going away from it. And so what does it do? It shows you ST depression. So anytime you guys see ST depression on an ECG, within the right clinical context of your patients, you have the history of presenting illness, the patient presentation, you interpret that ECG. If you see ST segment depression, one of the things you need to put really high right away on the differential is this the reciprocal change to an injury current that's heading in the opposite direction? Does that make sense? Yeah. It's a game changer because then it gives you confidence. No, this is real. I'm seeing what I think I'm seeing. If I'm seeing ST segment elevation here, well, the lead that's on the opposite side should be showing me depression. And if it does, you can confidently say that is an occlusion myocardial injury. So when you see ST depression, the first thing you guys should be thinking right away, is this the reciprocal change to an injury current that's heading in another direction? That lead is telling you, don't look at me. Look over there. Look over there and you'll find your problem. Okay, so what if the current, or what if the injured cells were on the endocardium? What if they're on the inside of the cell, of the tissue? Well, now you've got a current of injury going this way, from negatives to positive where it's injured. And so what do you get? ST depression as well. So, ladies and gentlemen, when you see ST depression on an ECG, you need to put at the two top things in your differential. Is this a reciprocal change of an injury current heading in the opposite direction of that lead, or is this potentially subendocardial ischemia, non-STEMI, the NSTEMI scenario? That's what you need to be thinking when you see ST depression. Is this the reciprocal change of an injury current going the other direction, or is this subendocardial ischemia? That's what you need to know. Once you guys get your head wrapped around that, ECG interpretation becomes way cooler, way more fun at 3 o'clock in the morning. Okay, everyone good with that concept? Any questions on that at all? We're good with it? Okay, perfect. Okay, so for the first time ever, I'm showing something called the current ECG systematic approach to ECG interpretation. I'm not kidding you when I tell you I've spent a very long time working on this with some colleagues and some industry experts. Because I feel like for years, there has never been an appropriate update to this. Everyone carries the card that shows the ECG, the leads, and it says the region of the heart. We all have it, everyone has seen it, it's everywhere. It's been completely useless to interpret with when you understand things like currents of injury. And so I said to myself, no, there has to be a better way. And so we've created this, the systematic approach to current ECG interpretation. It is wicked cool. It's a game changer at 3 o'clock in the morning, and it will help you, and I'll show you how it works. So the first part of it is this. So where I feel ECG interpretation has been lacking forever, okay, including when I was taught ECG interpretation, is the big gap is that we don't link cardiovascular anatomy and physiology with what we see on an ECG. In school, you were taught those sections separately. You were. But really, we need to combine them to understand more appropriately what is happening with our patients. And so here's the first part. If you look at this image here, the boxes that are in red, they represent coronary artery anatomy. And so you can see, branching off the aorta, you have your right coronary artery, and then that goes down to your posterior descending artery and the lateral right ventricle. Your right coronary artery splits, it bifurcates. The front of it goes down the right lateral wall of the left ventricle, and the other bifurcation wraps around the back and becomes the posterior descending artery. You can see that here. If you go toward the left, you have your left main that comes off your aorta. That splits and becomes the left anterior descending artery, the basolateral artery, and the left circumflex artery. But we're not done there. What's off your LAD, your left anterior descending artery, your first diagonal branch, and your second diagonal branch? There's your coronary artery anatomy in a nutshell, 3 o'clock in the morning. Now, how do we apply that to what we're interpreting? Well, have a look here. Let's pick an MI. Let's see if we can look at, if we find this baby blue box here, it says lateral left ventricle. So you think you see ECG changes in the lateral left ventricle. And you're like, okay, but where's the culprit lesion? Where's the coronary vessel that's being involved? Well, let's find out. Left lateral ventricle, if you go to the right and up, well, it could be the left circumflex. If we go left or to the left side and up, well, it might be the posterior descending artery. This will tell you the two arteries in this particular case that might be where the culprit lesion is. And some people may be saying, that's great, but why do I care about the coronary anatomy when I'm treating my patient at 3 o'clock in the morning? You definitely care. You care because knowing where the culprit lesion is within the coronary vessel can really impact your care and how the patient evolves in front of you. Right? How they change their hemodynamic status. So it's important to understand that link. If you look at another one, anterior left ventricle, you have changes on an ECG. Well, you go up, you go, well, could be the first diagonal branch, could be the second diagonal branch. So this is your first little tool at 3 o'clock in the morning to figure out where is this occlusion. Okay. Now, this is your classic image that you would have always seen, but we've changed it. So, if you have, as an example, if we look at leads 2, 3, and AVF, we can see that the leads 2, 3, and AVF, the right coronary artery may be the culprit lesion, where that's the highest probability. And if you look at these little boxes here, these are the letter I. They stand for the inferior portion of the left ventricle. That's the region those leads are looking at. I've also added over here on the side the modified 12 lead section, which has never existed on the cards. So we can see where V4 are, what vessels involved, what part of the heart it's looking at. Leads V8 and V9, which would be wrapping around the back, looking for posterior MI. So this will help you. The other thing that's really cool about this is that you also have it in writing down here. So if we find inferior that we just were speaking about, inferior, you can see, well, the inferior should be leads 2, 3, and AVF. To give you confidence in what you're looking at 3 o'clock in the morning when you're tired. And now, the other part that I think has been really missing forever is the reciprocal changes. Because remember, I was just talking about currents of injury. Right? The reciprocal change counts, because the reciprocal change is saying that injury current is heading in the other direction. So, if we look at the inferior leads, the reciprocal leads should be 1 and AVL. So if you see changes in your inferior leads at 3 in the morning and you're worried about acute coronary syndrome, you should be looking at lead 1 and AVL for the ST depression of the reciprocal change, saying that current of injury is heading in that direction. Does that make sense? It'll give you a ton of confidence when you're sort of not sure. It will help you. And there it's finally there for us. And I produce every single one of the reciprocal changes that should exist within every region of your heart. There's also something on this guide that's called the hexaxial reference grid. Believe me, you need to know the hexaxial reference grid going forward. Trust me on this one. Because when I did my training in advanced electrocardiography, I was basically the only person in the room. There was a bunch of doctors and physicians, cardiologists, intensivists. I was the only paramedic there. And they were talking about the hexaxial reference grid. I had no idea, and I was lost. Okay, and they all were basically turning to me and they were like, Dave, you got to study the hexaxial reference grid, then you'll be on board with this whole thing. So what they were telling me is basically the hexaxial reference grid tells you which leads look at what parts of the heart. Directly at what parts of the heart. So you have an idea of exactly where that current of injury is. And if you look at this lead 3, so lead 3 is looking at the lateral wall of the right ventricle. It also looks at the inferior of the left ventricle. It's in 2 dimensions. And the lead that's opposite is lead AVL. That's the most opposite lead to lead 3. So if you see changes in lead 3, you should see the reciprocal one in lead AVL. And they're color-coded. Notice that's baby blue, and those are dark blue. Baby or dark blue, baby blue, reciprocal changes. They're color coded, so when we're tired, and some people are more visual learners, you can say, no, no, this is what I'm seeing. The colors are matching up, they're working. This is right. Okay. Last thing. So, lots of people have asked me for a long time, how do you interpret an ECG? And I've never really, truthfully, been able to give a straight answer. Because I've never really thought about myself, how I do it. I just feel like I'm doing it and it's happening, and I'm not sure the process I'm taking. Okay? So I sat down and started to draw it out for myself. I started just basically interpreting hundreds of ECGs and mapping out how I typically am doing it. And so here's my version of a systematic approach to ECG interpretation. This is how I'm doing it. First thing I do, I get the history of presenting illness. So what's the patient telling you happened before you got there? Right? That's critical. The next thing is the patient's presentation. How does the patient look? And I've said this before, you guys don't ever let your partner or somebody else hand you an ECG until you have taken into account the history of presenting illness, the patient presentation, then you interpret your ECG. It makes absolutely no sense to have a patient who's sitting in front of you, who's pink, warm, and dry and smiling, and you have an ECG that says acute MI suspected. That doesn't match up. It doesn't make any sense. Right? It doesn't. Take the history of presenting illness, the patient presentation, then interpret your ECG. Those are the first two steps before I do anything. The next thing I do is I scan the tracing. So I'm looking for anything obvious that's just jumping right off the page. Right? Sometimes we're lucky. Sometimes things just clearly jump out at you. It's right there. It's simple to see. And so I'm quickly just scanning the tracing for badness. Is there anything that's just jumping off the page at me? That's my third thing. The next thing I do is I look at the rate. I try and figure what is the actual palpable rate and match that up with what I'm seeing on the monitor, because we treat patients who have hemodynamically fast and hemodynamically slow rates that are changing their hemodynamic status. So I want to know what the rate is. The next thing I want to do is I look at the rhythm, and I want to know, is it regular or is it irregular? Because that makes a huge impact. Now I'm starting to think about things like blocks and all kinds of other strange dysrhythmias in my differential. Next thing I'm going to do, I'm looking at the cardiac axis. And the cardiac axis means where are the leads looking, right? What part of the heart are they taking a look at with respect to the curves of injury? And that's where that came in. That will help you with your cardiac axis. Okay. The next thing is the QTC. I don't have time today to go on one of my all-time favorite rants, which is the QT interval. Please look for the QT interval. And on a break, if you want, I'll do a massive rant on it, and it'll be fun. But anyway, the QT little c. And what does little c stand for? Right, corrected. And what's it correcting for? Rate. It's correcting for the rate. It's getting everything to an average of 60 beats per minute so that you can rely on what you think you're seeing with respect to the QT interval. And you don't need to remember all the numbers they told you in school. 0.46 for a woman, 0.44 for a man. No. What you need to know is that if the QTC is greater than 0.50 of a second, it is too long. It's considered a clinically significant prolonged QT interval, and you need to worry about your patient and you need to tell somebody about it. Circle it and tell somebody, because people who have prolonged QT intervals are susceptible to a very specific form of polymorphic ventricular tachycardia. Who can tell me what it is? Yes! It's torsades. Right, torsade de pointe. That's my best French. If anyone's French, I apologize. Torsade de pointe. Twisting of the points. Did you know that torsades is caused by a preceding prolonged QT interval? Specifically, if the patient was in torsades, they had a long QT. Why? So I'm worried about the QT interval because I don't want my patient to go into torsades and not know what's happening. So I check the QTC all the time. Greater than 0.50, greater, it's too long. And then I'm looking at T waves. Do they show hyperacute T waves? Which, if you're interested in that, well, you can go to my podcast and I do a thing on it. Is there hyperacute T waves, which are the earliest sign of cardiac ischemia, or are these reperfusion T waves, which we can talk more about that another time. But vitally important to understand those two things. If you don't know what a hyperacute T wave is, or a reperfusion T wave, please come talk to me. Next thing we're looking at is ST depression. Is there reciprocal injury or subendocardial ischemia? We just talked about that. Those two things when you see ST depression. That's what I'm looking for. Next thing is ST elevation. don't rely on millimeter criteria, right? No offense to the cardiac monitor, okay, but biology does not work on millimeters, right? We're all shaped differently. The further an electrode is away from the heart, the smaller the complexes get. If I'm standing in front of you right now and I'm ashen gray and diaphoretic, and the monitor says 0.8 millimeters of ST elevation, please treat me like I'm having an infarct, right? Because the monitor may not say it until it reaches 1 millimeter. Biology doesn't work on millimeters. Morphology is what counts. The morphology or the shape of the ST segment is perhaps a more accurate diagnostic tool for figuring out if a patient is suffering from acute coronary syndrome. Morphology counts. The shape of the ST segment. Normal ST segment morphology should be concave in. Isoelectric line concave in. But if you start to see straightening or convexity of the ST segment, this is not good. Something may be wrong. Worry about morphology. The monitor may not be able to tell you that. And the last thing is call for help. Admit when you don't know something, or admit when you're unsure on what you're interpreting. Ask your partner. Find another resource, right? Knowing to call for help is vitally important because we don't know everything. So when you feel like you're not sure, ask somebody about it. Perhaps they are able to interpret something that maybe you didn't see. Everyone cool with that? Okay. How am I doing? Yeah?
Dave,
Yeah.
I have a question, really quick.
Sure.
I really like the part about the axis and sort of what that tells you about the heart. But how do you account for the fact that you're applying a 2D axis to an inherently three-dimensional structure that's not applied flat in the bottom?
Yeah. So good question. So you have to do your homework and study which leads look in 2 dimensions versus 1. She's getting into a really good topic. I don't have time this second, but basically there's only 2 leads that look in one dimension. Lead 1 and AVF. They look specifically at one area. The rest of the leads see everything in 2 dimensions, meaning they see 2 big parts of the heart. That's how you account for it, but I can talk more about that. Is that cool?
Yeah, thanks.
Okay. All right, so last part of this presentation, lead AVL. Now, I'm happy to go on about lead AVL, and lead AVL is something we all need to be aware of. Because for years, we've been told you cannot interpret an ECG unless there's 2 changes in 2 or more contiguous leads. Remember that? You had to have changes in 2 or more contiguous leads to be considered significant. That's not true. And AVL has proven it. Okay, the most stunning first change you will see in the presence of an impending inferior wall MI is ST depression in lead AVL alone. Just that lead. So look for lead AVL. Now when I heard that concept, I was fascinated by it. I thought, yeah, this is cool. Okay, right on. Excellent. But I thought, well, wait a minute. How is that possible? Because I know from studying this that lead 3, and we've shown you now, lead 3 and lead AVL, well, they're considered the reciprocal leads to each other. But before I understood that hexaxial reference grid, right, I assumed that lead 3 and lead AVL were directly across from each other at 180 degrees. I didn't know that it was different. And so what happened was, is I wrote Dr. Stephen Smith. You may have heard of him before, a guru in ECG interpretation internationally. I wrote Dr. Smith and I said, Dr. Smith, this finding about AVL is fascinating. I said, but how is this possible? Surely, if there's a change in lead AVL, lead 3 would show it. Why is that possible? And he wrote me back very kindly saying, David, you need to study the hexaxial reference grid, like they all told me again later. And he said, because lead AVL is not truly 180 degrees across from lead 3. It's not perfectly opposite. Lead AVL is on a slight angle. It's the most opposite to lead 3, but it's on a slight angle. And he said for that exact reason what's happening is lead AVL is basically catching the inferior wall MI out of the corner of its eye. It's seeing the changes first. The lead AVL is seeing the injury current first. It's seeing the reciprocal change first. And then as the MI gets bigger, then lead 3 starts to show you your changes. Lead AVL is seeing an injury current heading away from it first, ahead of the one in lead 3. And that is why you're able to say that lead AVL will give you the most stunning first change in the presence of an impending inferior wall MI. Lead AVL alone. So think about lead AVL. Remember that. It's important. Again, that's why currents of injury, when you understand them, you become way more adept at ECG interpretation. It's way more fun. Let's do a couple examples. Okay, look at lead AVL. What do you see here? ST segment depression and downsloping. Clear? It's subtly there, but it's definitely there. But look at the leads 2, 3, and AVF. What's the monitor going to say? Sinus rhythm. Most of them will say sinus rhythm. But you guys are smarter than that. You're interpreting this and you're like, no, wait a minute. History presenting illness, patient presentation. I got ST depression and lead AVL. I think this might be the reciprocal change to a lead happening in the opposite direction. Remember, lead AVL is saying to you, don't look at me, look over there. There's a problem heading that way. And actually, when you get really into this as a skill, and I can help you do this, is when I see this dude, what jumps off the page of me too, and I won't get into it today because of time, but I really wish I could, is that leads 2, 3, and AVF have massive hyperacute T waves here. They're massive. But that's helping give me confidence in that. But for today, lead AVL, ST depression, there it is, impending inferior MI. Here's another one. ST depression and lead AVL, look at 2, 3, and AVF. To the untrained eye, most people wouldn't see that at all. They think, that looks like sinus rhythm, just crumple up garbage. Right? But you guys are clinicians and know this. Lead AVL can change that. Do you guys see the depression in lead AVL? That's definitely an impending inferior MI. No question about it. And now you can see again, these are big, what are known as hyperacute T waves. And on another time, in another place, we're going to go over that. Because I need to get it out of me. All right. Here's one that's more obvious. Lead AVL, ST depression. I mean, look at these changes here in 2, 3, and AVF. These are very strong morphology changes. The shape. The monitor may not pick this up just yet, but this is clear straightening, 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 and convexity here. Do you guys see those morphology changes? They're obvious in 2, 3, and AVF, and you have an injury current that is saying, hey, don't look at me, look in the opposite direction. How am I doing for a time, Brett?
Yeah, 10 minutes.
Perfect. I have time then to tell you one other cool thing. Sweet. All right. Yeah, so remember we were talking about injury currents, that the electrode that sees the injury current coming toward it gives you that ST segment morphology elevation. Ready for this? Once you get that idea wrapped into your head, next thing you do when you see ST elevation on an ECG, find the lead with the greatest amount of ST elevation, and that is the lead that is looking most directly at the current of injury itself. It's actually telling you specifically where that area of myocardium is hurting. The lead with the greatest amount of ST elevation because the injury current is pointing most directly at it. Isn't that cool? So look here. Lead 3 is the biggest amount of elevation here. Lead 3 is telling you there's an injury current staring right at it. And that's the area of myocardium that's being affected. And when you understand that, then you're worried about your patient's vital signs and preload and all the other things that are going to happen. That's what makes you a strong interpreter and a clinician. Okay? Now, last one. I think this is the last one. ST depression of lead AVL, 2, 3, and AVF. Subtle morphology changes of straightening, starting to straighten out, definite straightening, but lead AVL is the tip-off. It's telling you the reciprocal change is there first. Don't miss this at 3 o'clock in the morning. Don't. And keep doing serial ECGs. Eventually, the big change will show up, the monitor will say it, but you'll be there minutes to hours ahead and save myocardial tissue. That's your family member, that's your loved one, that's everyone else. That's the 28%. And remember, sugar, water, oxygen to survive. The eyes can't see what the mind doesn't know. And in Klein's world, who gets an ECG? Almost everybody. Safer. So if you guys would like some more information on this sort of stuff, I've just launched a website called currentecg.com. It's a video podcast series that I've grouped with a couple of experts in the US I did training with. What's happening is I've recorded a bunch of monthly episodes that you guys will have access to in that bank, and then every month, me and a few of these experts in the States, we're putting out cases. And if you guys have cases you want us to talk about, then ask for them, and we'll do it. Right now, I launched this about 3 days ago. As a shameless plug, there's the first 50 people who signed up get a one-time free download of my current ECG systematic approach to ECG interpretation I showed you today. There's 8 of them left. So if you're interested, please go to the website and subscribe. I thank you for your time.
before we head to break, we have a couple of things, but any questions for David before we thank him and let him sit?
Any questions at all?
Here we go.
I have another
Oh,
question.
here we go. Fire away. Yeah, please.
Okay, so I get that morphology is more important than sort of millimeter differences. And in general, I think we all see that when we have huge changes, we think worse. And I think that's sort of fair to say. But is there a way to track the amount of change on ECG to the amount of repolarization to the amount of subsequent cardiac injury and outcomes? Or is that are there too many other things in here? Like,
Do you mean like if the morphology is getting bigger, that means the myocardial damage is getting larger?
yeah, so like, is there a way to be like, if we have, we see sort of this much change when there's this much change in the amount of repolarization?
No, it doesn't work like that. And that's a great question. That's why subtlety counts. That's why you need to have subtlety and know about that. A perfect example, I won't get in, but here's a great example, is lateral wall MIs. The lateral wall of your left ventricle is considered electrically silent because the lateral leads are physically and anatomically further away from the heart. There's lungs in the way, there's air in the lungs, and that subtle morphology changes on an ECG in the lateral wall mean massive occlusion and huge injury, and they may never get bigger and show up as these big tombstones. They may only ever stay subtle because of things like that. So know that you're not necessarily looking for massive morphology. If you have a morphology change and the reciprocal change, big problem. Cool.
Is there anybody else? All right, well, from the PAPEI's organization committee, a little gift to say thank you and really.
Great, thanks a lot.
Hold everybody, we won't take a break yet. We have one of the sponsors is here, and we'd like to just have a moment of our time. So Michael Davey from National Bank, if you're available, you come on down and take the money.
Hi there. Good morning, everyone. I know it's almost break time, so I won't take too much of your time here. I'm the branch manager at the National Bank in Charlottetown. It's a pleasure to be here today. National Bank is a proud supporter of paramedicine. In fact, we have a made-to-measure program for paramedics. We're the only financial institution to have such a program. National Bank is a big supporter of the healthcare industry throughout the country, and that's why we're here today. The bank is very committed to the development and improvement of healthcare, and for that reason, we're here at your symposium today. So thank you very much for having us. We have a booth outside there. Please stop by. We have our advisors and our assistant branch manager there ready to talk about our program, and we have a contest where you can win $5,000 for a trip of your choice. So thank you very much.
We'll release you to break. Just while you're out, there is a question box in the restaurant. So our panel discussion will be how we end the day. It's going to be downstairs. So after we move downstairs to all the individual stations, we'll bring us all back together, but stay downstairs for the panel discussion. And we're trying to get questions from you guys. So there'll be some information near the box. There are comment cards there. Write out some questions that you'd like to see discussed by our panel. And our panel includes Dr. Scott Cameron, Provincial Medical Director of Prince Edward Island, James Sullivan, Director of VHS in Prince Edward Island, I believe Carl Walchuk, who's is not here, but we're reading a statement, Ryan O'Meara, President of PAPEI, is going to be a statement from Carl, who is the Registrar of Nova Scotia College of Paramedics, and I think I sit on it as well. So please, if you have any questions that you'd like brought up in the panel,